where should we start? Let's start by considering mammograms. This is a paper published in 2021 discussing mammograms and mortality. That is the key factor. Once again, remember, we are talking about all-cause mortality. We're not talking about disease-specific mortality. This author even does a great job of going through the history of mammograms and how we came to establish our current mammogram recommendations. Notably, it started with cervical cancer, the Pap smear. The publications on Pap smear, this is a more recent study than 1973. This was 1994 this was published, but there was a reduction of 50% in cervical cancer mortality. Now, that is disease-specific mortality. That's an important difference. However, these are young women overall, between 40 and 60 years old, 40 and 70 years old. So preventing cervical cancer deaths in that population, because they had a pretty low risk of death to begin with, dropping that by half was probably significant. And that was the early success that led us to the idea that early detection was important. And I want you to pay attention to that moment, because we got it into our little heads that early detection was the key. And we took that and we expanded it to everything, everywhere, all the time. Let's go back to mammograms. Decades of evidence reveal a complicated relationship between mammograms and mortality. That is hardly a ringing endorsement, is it? Let's get into the complications. Mammograms may detect deadly cancers early, but may also lead to the diagnosis and potentially fatal treatment of cancers that would never progress to cause symptoms. Mammography can detect some early-stage cancers that will never progress to cause symptoms, referred to as overdiagnosis. In such cases, the emotional, financial, and physical costs of a cancer diagnosis and any subsequent treatments occur without any corresponding health benefit. But because it is hard to tell which women will be harmed by their cancers, there is a tendency to treat all women as if their cancers will be lethal, even if the initial cancer would have never proven life-threatening. Exposure to chemotherapy, radiotherapy, and surgery can potentially lead to new conditions. These are exactly the same things I've talked about. In all age groups, mammography has increased dramatically. And here is the chart. Mammogram within the last 2 years, markedly elevating since 1987 to 2015. Here is the breast cancer incidence by stage, 1975 to 2015. Early stage breast cancers took a tremendous leap up. We were catching it early, right? Once again, overdiagnosis is difficult to identify. If a mammogram catches an early stage cancer, it is impossible to discern how that cancer would have progressed absent detection, especially for a given individual. Several types of evidence suggest overdiagnosis. For instance, autopsy studies showing that almost half of older men die with, but not necessarily of, prostate cancer has been important to prostate cancer screening guidelines. Autopsy studies also suggest overdiagnosis of thyroid and breast cancer, and time series evidence suggests overdiagnosis of thyroid, melanoma, and kidney cancer. As diagnoses have risen dramatically with screening, deaths from these types of cancers have been stable. Once again, we are detecting it early and having zero impact on mortality. Deaths from breast cancer have decreased as mammography has increased, but differences in the decreases across geographic areas suggest overdiagnosis. The greatest reductions occurred in countries where screening was less common. So there may be some value in some screening, but more screening may not provide additional benefit. Blair and Welch in 2012 provide an approach that quantifies overdiagnosis from screening. The goal of screening is to prevent early-stage cancers from progressing to a later stage. Therefore, an increase in early-stage cancers without a decrease in late-stage cancers of the same magnitude indicates overdiagnosis, under the assumption that late-stage cancers will be detected regardless of screening. This is a critical point, is that if a screening program is effective, yes, you should catch more early-stage cancer. But there should also be a decline in late-stage cancer that is the same amount as the increase in early-stage cancers you detect, because you are preventing the early stage from moving to late stage. That's not what we see. This is indicative more of overdiagnosis than effective screening. Evidence of overdiagnosis from randomized control trials is the most compelling. Trials should find a higher rate of cancer in the intervention arm in the short term, and in the long term, if the only impact of screening is to detect cancer early, rates of cancer should converge in the intervention and control arms. A failure to converge after a reasonable amount of lead time indicates overdiagnosis, and overdiagnosis became apparent in the lung cancer screening trial based on 16 years of follow-up data. Since then, overdiagnosis has become apparent in 2 studies of mammography trials based on at least 15 years of follow-up data, which imply overdiagnosis rates of 5 to 55%, depending on the subgroup and base rate. The author points out overdiagnosis, though undesirable, might be tolerable if screening reduces mortality. So, the rest of this paper is evaluating mortality. The 2016 guidelines for mammography screening from the USPSTF are based on meta-analysis. All trials combined include over 600,000 women. Overall, the meta-analysis finds no statistically significant reduction in all-cause mortality for women in any age group. Some trials even show imprecise increases in all-cause mortality across all age groups or within an age group. Results focused only on breast cancer mortality are slightly more promising. Meta-analysis finds statistically significant but small reductions in breast cancer mortality for women in their 50s and 60s, and finds imprecise reduction for women aged 39 to 49. We're going to review those trials, but once again, consider this. If there is a decrease in breast cancer deaths, but there is an increase in other deaths from anything. That could be from getting hit by a bus, that could be from the side effect of treating breast cancer, that could be from anything. But if these 2 things occur together, then there will be no change in all-cause mortality. So for the rest of this, let's focus on deaths from breast cancer and all-cause deaths. This first chart, Table 2, shows each trial included in the meta-analysis and what its commentary was on the effects on breast cancer mortality. That's disease-specific mortality. What I want to focus on is this confidence interval. When a confidence interval crosses the number 1, if the number 1 is between these 2 numbers, the finding is not statistically significant. I want you to notice how many trials found no statistically significant difference. Each one of these includes the number 1. Every single trial that has ever been run in women aged 39 to 49 years has not found a statistically significant reduction even in disease-specific deaths. As a result, the USPSTF increased the recommended screening age to age 50. Even in this population, almost every single trial found no statistically significant reduction. This trial did. Notice that this range does not include the number 1. This was, I believe, a Swedish trial. This trial found a benefit, and this trial found a benefit. Out of 8 trials that have been performed in this age group, 3 found some benefit in breast cancer-related mortality. This is disease-specific mortality. In women aged 60 to 69 years, there are a few more studies. 4 out of 6 studies found a statistically significant reduction in breast cancer mortality. So Age 60 to 69, there may be some value in reducing breast cancers. And once again, after age 70, each and every trial includes the number 1, no statistical significance. Let's look at all-cause mortality. Once again, the number 1 is included in virtually every single number. Even the estimates are at 1, by the way. Even the mean is at 1. There is no detectable difference in any age group on overall mortality from breast cancer screening. This is the difference between disease-specific mortality and all-cause mortality. Once again, here we see that there was zero difference in all-cause mortality. You may have reduced deaths in women aged 60 to 69. You may, if you squint at it, reduce breast cancer deaths in aged women 50 to 59. But women died at the same percentage rate despite those reductions, even at those ages. They just died from other things. In the commentary here is a really critical bit of information. It is hard to understate the controversy surrounding the results from mammography trials. The idea that finding small, treatable cancers will save lives by stopping them from growing into larger malignant cancers is appealingly simple. For advocates of mammography, it was thus disappointing when the evidence from randomized controlled trials was underwhelming. As a starting point, this author examines breast cancer mortality and all-cause mortality 20 years after enrollment in the study, which is the maximum follow-up length available. What he found is that breast cancer deaths were reduced by 20 fewer deaths from breast cancer per 100,000 women, a very tiny fraction. There is a slight increase in all-cause mortality rate of 89 per 100,000. A fewer number of women died of breast cancer, and a slightly higher number died overall in the mammogram, no mammogram group. Why would there have been an increase? There are many mechanisms that could explain the trend in all-cause mortality. Breast cancer treatments could have mortality impacts that are not captured by breast cancer mortality. Randomized controlled trials of radiotherapy show that it increases lung and esophageal cancer mortality among women treated for early-stage breast cancer. From these 3 causes combined, I find an additional 3.6 excess deaths per 100,000 women. This trend is statistically significant, and it can explain more than half of the trend in all-cause mortality. How have our institutions responded? One response is to incorporate it into new policies. The USPSTF ties health insurance coverage for preventative services to current and future guidelines of the USPSTF. However, the Affordable Care Act makes an explicit exception for mammography, allowing coverage for annual mammograms for women in their 40s despite current guidelines. The political and cultural factors are divorced from the science. And the political uproar of not covering mammograms that harm women and increase their risk of death have prevented it from falling out of healthcare coverage. For example, in California, state auditors implemented a policy that required many elderly women enrolled in a particular health plan to receive at least 1 mammogram. The average age was 81. Unsurprisingly, 17% of these women experienced significant burdens from mammography. The policy was later reversed, but the issue of screening older women persists. One doctor told Kaiser Health News that doctors continue to screen older women because of fears of lawsuits, health system bonuses for high screening rates, and because doing less can be perceived as a lack of caring or ageism. It can be uncomfortable for a physician to explain why doing less is